Hi, thanks for coming. My name is Ilan Kedan. I'm a cardiologist at Cedars-Sinai Heart Institute. I'm here to talk to you about the use of point-of-care ultrasound to guide management in heart failure. Ultrasound has become an integral part of modern-day healthcare. The role of ultrasound continues to expand as the technology becomes more accessible, portable, affordable, and the expanding role of ultrasound will create applications that we haven't even identified yet. And throughout the course of my talk, I'll have on the slides images that have been acquired at the point of care, at the bedside, that have been imported into our electronic health record. And I just, as examples to kind of guide you in how I'm building the argument for use of handheld ultrasound in daily management of heart failure. Point of care data, or is the medical care or information provided or acquired in the presence of the patient. So you can acquire the information as a physician or a non-physician, as Mr. Spock is using his machine to get information about a sick person. The data that you acquire at the point of care is better. It's been demonstrated as a better predictor of success when, especially, it's automated as a part of decision making, and within the workflow, the odds ratio as a predictor for success is over 100. And when you're at the point of care, when you're in contact with the patient, your odds ratio for success is 15. When we're using physical examination, our goal is to formulate a differential diagnosis to diagnose, assess our treatment, guide management of care, specifically volume management and target medication titration in heart failure patients, understand our patient's health status, stratify risk, and screen for disease. The targets for ultrasound at the point of care are most structures head to toe, superficial to deep, solid organs, and superficial structures, vascular structures, soft tissue structures, joints, anything close to the skin we can image as well. In the acute care setting, use of point-of-care ultrasound, handheld ultrasound, is very well validated. It's actually standard of care, and what they've done to kind of simplify the whole process is create a binary decision tree. Is there fluid? Is there not fluid? And with the FAST exam, you look in 4 spots to look for pericardial fluid, pleural fluid, intraperitoneal fluid, and retroperitoneal fluid. It's very sensitive for detecting fluid and very accurate in detecting intraperitoneal bleeding that requires emergent surgery. Of course, it's operator dependent. In heart failure management, we have a physical exam, which is limited. It's subjective, indescriptive, qualitative. It requires follow-up testing, and it's personal. We listen to hearts, we hear a sound, we don't share that, we can't record that, we can't put that in the health record for other people to observe and compare with. With ultrasound, we can be objective, quantitative. We may actually make a diagnosis. The information is shareable and it's reproducible. When we're assessing patients with chronic heart failure, we're listening to their heart, lungs, we're palpating their abdomen, checking for peripheral edema, and assessing their neck veins. These are very difficult things, again, not quantitative. With a handheld ultrasound, we can do all of those things and more, and quantitate, and record and input into the health record for comparison serially over time. So this table is another example of what actionable data we can actually acquire at the point of care when you're with the patient at the bedside. On physical exam, you can argue that there's very little actionable data that you can acquire with a physical exam, but handheld ultrasound, if you're skilled enough, you can actually acquire a great deal of actionable data that will change management. When anticipating heart failure hospitalization, what we see are patients who are symptomatic and have already gained weight. Our goal with management of chronic heart failure is to drive the filling pressures down and personalize the care. So our goal would be to anticipate changes in filling pressure prior to progression of autonomic adaptation, increased intrathoracic impedance, weight gain, and symptoms in heart failure hospitalization. So an example, this is a real example of a patient that we follow in our heart failure clinic. This is in the decompensated state on the left of the screen, bilateral pleural effusions, dilated IVC, not collapsible, diuresed, optimized medically, followed up. A few months later, same measurement, IVC, caudal to the middle hepatic vein, collapsed, bilateral pleural effusions gone, patient better. So it doesn't go from, the IVC doesn't go from dilated to collapsed in one day. There's a progression. You can follow that progression over time. In our clinical experience, we created a heart failure program to manage patients prior to being enrolled in a advanced heart failure program, or patients who are unsuitable for advanced heart failure therapies. We're a large referral hospital with a diverse population in central Los Angeles, and many of our patients are managed care patients with capitated payment models. In our program, we enrolled patients in an ongoing fashion and followed their data and their hospitalizations 6 months post and 6 months post and 12 months post enrollment in the program, and compared that hospitalization and hospital use to the 6 and 12 months prior to enrollment in the program. Our program focused on heart failure optimization, which was run by a clinical pharmacist. We developed a medicine-based protocol and used serial BNP measurements, serial point-of-care IVC measurements, and ultrasound measurements with the patients each visit to assess the need for IV diuretics and thoracentesis, outpatient thoracentesis. Our initial findings we had two initial findings. One, the IVC diameter, the absolute IVC diameter, correlates with the heart failure hospitalization. And the use of point-of-care ultrasound to guide management in a multidisciplinary treatment model decreases hospital utilization. So this patient we were following for 4 years in the clinic, and he was decompensating, developing cardiorenal syndrome, so we admitted him in the hospital service, and we initiated inotropes and pressors, and we were able to diurese him and make him a suitable candidate for ventricular assist device. Now he's waiting for a transplant. With our inability to bring down his filling pressures, his IVC diameter remained large, and with pressors and the initiation of pressors and diuresis, we were able to drive down that filling pressure and improve his renal function and make him a suitable candidate for advanced heart failure therapies. Here's our data from our IVC measurements. The mean IVC diameter in patients who were hospitalized was greater than the mean for patients who were not hospitalized. The smallest maximal IVC diameter, so as we diurese the patients, the lowest we could go, the higher that was, the more likely the patients were to be hospitalized as well. So here's another way of depicting that. For every ½ centimeter increase in IVC diameter, we were associated in our patient population with a 36% increased risk of hospitalization. The admitted versus non-admitted patients had a significantly larger IVC diameter, and the IVC from 2 to 2.5 carried with it a risk ratio of 1.81. From greater than 2.5 and up, risk ratio greater than 2.23. Here's the data of hospital utilization for this same cohort of patients. All-cause inpatient stays down 45% in 6 months. All-cause inpatient days down almost 60% from the 6 months prior to enrollment in the program. And at 12 months, this is a population that's 12 months sicker and 12 months older. The effect of the program and the use of handheld ultrasound is durable. 50% decrease in hospital inpatient days, and all-cause inpatient stays down 36%. So here's some clinical examples I just wanted to give to help to help communicate how we're using this data. And these are actually screenshots from our electronic health record with superimposed arrows. So this is a patient who has an ischemic cardiomyopathy, ejection fraction 25%. We're managing in the office, and he has 3 days of dietary indiscretion. He ends up hospitalized. Now we know around 2.1, 2.2 is where he's going to decompensate, end up being hospitalized, and we can titrate his medication and increase intensification of his therapy and follow-up if he starts to approach that 2 centimeter diameter for his IVC, in addition to using other markers. Another patient, 92-year-old myelodysplastic syndrome with congestive heart failure, non-ischemic cardiomyopathy, who was doing well and then decompensated, ended up hospitalized. Hemoglobin severely anemic. The patient was diuresed and transfused, and now we have another thumbprint for when she starts to get in trouble. We can look for other kinds of features. We can have someone go to her home. We can check on her, check hemoglobin from her with a home visit, just to keep her from coming back into the hospital. This is a complicated patient. This is some data from after enrollment in our program. This is a patient over the course of approximately 6 months. We were able to drive down the IVC diameter, and a little more information about this very challenging patient. HIV, morbid obesity, chronic kidney disease, diabetes, non-ischemic cardiomyopathy, on 15 medications, was hospitalized 10 times in 2 years prior to enrollment in our program. We were able to drive down that vena cava diameter, treat the patient, diurese the patient, and clinically stabilize the patient to the point where he had 1 hospitalization in 1 year after being in this program. And this is an end-stage type of picture. So, in summary, the future of handheld ultrasound and heart failure, this is a new area, so we need to work together to standardize our measurements and create a common dialogue or a common language for how we're measuring these diameters and what we're measuring and how often we're measuring. We need to expand the use of handheld ultrasound to physician extenders, non-physicians, and acquire images in a subacute care setting or even in the home setting, and also have remote image transmission and monitoring.